thank you very much to the organizers as well. It's really my pleasure to be here. This is actually my first time to India, so I'm really having a great time. Thank you to everybody. What I'm going to be speaking about today is hematopoietic cell transplantation late effects, and I have no conflicts of interest with this talk. Let's see. Okay. So I think, as we all know, hematopoietic cell transplantation is a very effective treatment for many malignant and non-malignant hematologic diseases. And in fact, the 1 millionth transplant was actually performed in December of 2012. That includes both autologous and allogeneic procedures. But the success, unfortunately, is limited by a number of considerations. First of all, it's very expensive, and that's a problem in resource-limited countries. There's a lack of donor availability if you're having an allogeneic transplant. Disease recurrence continues to be a problem even post-transplant. And then there's a number of treatment-related complications. I think we're doing okay on the early ones. I think we've made improvements with less intensive conditioning and better supportive care. But the topic of my talk, which are the late effects, I don't think we've made as much progress. So this slide just shows the distribution of transplants from 2006 to 2008. And it was published by Agarwal and Haematologic in 2013. And you can see that the majority of transplants are performed in Australia, actually, in Canada and the US and Western Europe. And over there in India, in the pink, you can see that it's really not a very common procedure per capita still in India. This slide is from that same paper and just shows the trends in transplantation across the world. And I'd like to focus your attention on panel B here, E, and up here on A. Sorry, can you hear me okay with the microphone? Okay. So in panel B, what they're showing is the distribution in 2006 of the transplants that were performed. And Europe and the Americas clearly do most of the transplants. However, if you look at the trend in 2007 and 2008, you can see where the highest percentage increases are. And it's actually in Asia and the West Pacific and in the Middle East and in Africa. Over on panel E, it shows you the change in the indications for transplant, with the leukemias increasing rapidly in 2006 to 2008, but also the non-malignant disorders. And I think quite a few of the transplants done in India are for non-malignant indications. And then in panel A, up at the top, it's just showing you that although autologous transplants are still increasing, the greatest percent change is in the allogeneic procedures from related and unrelated donors. So the greatest percent increases over this time period were in Asia, in the West Pacific, Africa and the Middle East, the non-malignant diseases, leukemia, and allogeneic transplants. This slide just shows the transplant activity in the United States, again showing the same trend with an increase in autologous transplants shown on the top, and the related and unrelated donor transplants shown in the blue and the green. And so in the United States, we did 7,800 transplants from allo donors in 2011. That 10,000 transplants were autologous. So what's the status of transplantation in India? And we're going to hear a lot more about this during the conference. But through 2011, apparently there were 1,600 autologous transplants performed. 50% of those were for myeloma, 31% for lymphoma. A greater number, and this is unusual because most of the rest of the world, autologous transplants outnumber allogeneic transplants. There were 2,400 allogeneic transplants, 33% for acute leukemia, but 26% for thalassemia, and a fair number for aplastic anemia. Most of those allo transplants were from HLA identical siblings. It seems that there's still few from unrelated donors, from umbilical cord blood, and from haploidentical donors, although those are increasing in the rest of the world. My understanding is there's no unrelated donor registry in India, and so if you need to find an unrelated donor, you're going to other registries. One of the problems, of course, is that patients have to pay for their transplants. And I was able to find a statistic that said it costs about $20,000 US for a transplant, which is about 1.2 million rupees at current exchange rates. So that's a lot. It's out of range of most Indian citizens. On the other hand, when you think about it from a societal perspective, it turns out that that amount of money is about the same as 3 years of transfusion therapy and chelation, or about 4 times the cost of a single immunosuppressive treatment course for aplastic anemia. So in many other countries where they've done a cost-benefit ratio, it actually turns out that it's cost-effective to transplant patients early when they do well, because you're actually going to be saving all the supportive care costs over the years. So even if you're not increasing the number of transplants, even if you continue to do the same number of transplants, your number of survivors is going to increase over time. And these are some data just looking at the US statistics that shows that between 2009 and 2020, the number of survivors is about going to double. And you can see that over time, with more projections, it's going to even triple. So we have to think about these survivors. And what's clear from many studies is that transplant survivors have a higher mortality than the general population. It's estimated to be about 2 to 9 times. For autologous recipients, this means elevated risks up to at least 10 times post-transplant. And for allogeneic recipients, this is up to 30 years after transplant, and it results in a 30% lower life expectancy, which means that if you have a transplant survivor who survived without relapse of their disease for 2 years, their subsequent survival for autologous recipients is about 80% at 10 years, and for allogeneic, it's about 85% at 10 years and 80% at 15 years. So that's pretty good, but we're still losing a lot of our patients even after they get out 2 years. And what can be done about that? So one of the second cancers, for cardiovascular and pulmonary diseases, and for infection. And so you can see that the pie is definitely shifting, but many of the same targets are there. Well, how do we know this is any different? I mean, this is the cause of death of the normal population, right? And so this is from information from Fred Hutchinson, which addresses that question. What you have to do is compare the survival of your transplant patients to the age and sex-matched general population. And you can see that that is the dotted line on the bottom. For 5 years to 30 years after a transplant, the transplant survivors still have a higher mortality rate, and it's actually increasing with time, and quite consistent between the autologous and the allogeneic recipients. So now I'm going to shift a little bit to morbidity. Mortality is clearly higher. What about morbidity? These are some data from the bone marrow transplant survivor study that looked at the cumulative incidence of grades 1 to 5 chronic health conditions in the allogeneic recipients as well as the autologous recipients. And you can see it starts here with 2-year disease-free survivors. You can see a very steady and inexorable increase in the number of chronic health conditions in both of these groups. There is a statistically significant difference. The allos have more, but you can see that the autos have a very similar pattern. In addition, these investigators also were able to compare these outcomes with siblings, so people who had the same genetic and the same otherwise upbringing, and they found 3 times the rate of grade 3 to 4, so those are severe or life-threatening conditions in the siblings, in the transplanted patients compared to their siblings. So what is the real risk of having these late complications? And these are some data from Fred Hutchinson that looked at about 14, I'm only presenting a smaller number here, different potential late complications, and looking at what the rate was before the patients came into transplant and then what was the subsequent rate, to at least begin to get at this issue of, is it the disease, is it all the treatment that they had before they came into the transplant, or is it the transplant itself that is causing these things? I just want to focus your attention here on the right in the beginning for the allos to show the extremely high rate of pulmonary complications, iron overload, osteoporosis, diabetes, even adrenal insufficiency and hypothyroidism. And this p-value on the side compares the rate in the autologous transplant survivors versus the allos. But you can see that there's a number of things that are very high in the autos as well. So osteoporosis in about 10% of the autos, hypothyroidism in 14%, and other things. This was in about 500 allo survivors and 500 auto survivors. The median follow-up was very short. It was only 3 years, so we expect these numbers to increase. And I'm not showing you these statistics for relapse, chronic graft versus host disease, and second cancer. We think about them a little bit differently. This is some work also from the Hutch by Dr. Kara, who had done that previous figure, looking at the number of late effects and their cumulative impact on quality of life and functional status. So what you're showing here in the golden are the numbers of patients who had 2 or 3 or more late effects. And you can see it's really balanced and it's much higher in the allogeneic survivors. In addition, Dr. Kara was able to show that when you had 3 or more late effects, you had a much lower physical functioning score, lower Karnofsky score, you had limits in the normal activities, and this is what the patients are telling us from their surveys, and you're less likely to work. When she flipped that around and said, who's likely to have poor functioning and poor quality of life, Turns out that 4 complications, so joint replacement, diabetes, adrenal insufficiency, and pulmonary disease, were really strongly correlated with poor functional status. So not only do we want our survivors to live, but we want them to thrive as well. So we need to do something about these late effects. Well, those were all patients who had malignancies. What about patients who had non-malignant disorders? These are some data that were just published in Blood that looked at 20-year survivors who were transplanted for thalassemia. It was 109 transplanted patients. They had a great response rate. It was 84%. And these patients were transplanted from 1982 to 1998. They received myeloablative conditioning with busulfan and Cytoxan, and 18% of them had a history of chronic graft versus host disease. In these 20-year survivors, their quality of life was actually quite good. They had the same rates of getting an education, of having a family, of their general reports of quality of life. However, they did report worse general health than a general population control, especially if they had chronic graft versus host disease or other comorbidities. What these investigators then also did was they went out and they found 124 thalassemia patients who had not been transplanted. They had received just supportive care. And when they assessed those patients, they found that the transplant patients actually had better quality of life than these patients who had not been transplanted. They had better role functioning, physical and emotional, and less bodily pain. And so this would argue that actually transplants, particularly for long-term survivors, can result in good quality of life. And this is one of the few studies that compared it with patients who had the same disease but were not transplanted. So in the next few slides, I'm just going to summarize a lot of data, most of them case series or descriptive things, but to look at the different types of late effects and what we know about them. So I'm going to look at relapse, which really isn't a late effect, but we've got to keep it in the picture. Chronic graft versus host disease, second cancer, organ failure, infections, bone loss, endocrine disorders, so hypothyroidism and diabetes, and psychosocial distress. And if we look at the incidence, and this is actually supposed to be autos and allos combined, but for chronic graft versus host disease, that's very common in the allogeneic population. In addition, relapse, infection, bone loss, endocrine disorders, and psychosocial distress are very common. Second cancers and organ failure are actually not as common, but obviously have a lot of morbidity and mortality. You can see the top 5 that I had presented in those late causes of death in terms of mortality: relapse, chronic graft versus host disease, second cancer, organ failure, and infection. But a lot of these other things have quite a bit of morbidity, including diabetes and psychosocial distress. What about what's treatable? Well, unfortunately, I think we haven't done as well. Relapse and organ failure certainly can be treated, but can they be treated successfully? Often not. Chronic graft versus host disease and second cancers can be treated, but again, how successful are we? Infections, bone loss, diabetes and hypothyroidism, and psychosocial distress. So there are certainly treatments. Unfortunately, the last column is the most depressing. That's what's going to be preventable. So I think we can prevent some infections, we can prevent some bone loss. Chronic GVHD, I put a plus up there, but it's really something you need to do at the time of transplant by manipulating who you choose for your donor and how you do your transplant. Post-transplant interventions to prevent chronic graft versus host disease have not proven successful. But look at all those minuses. At this point, we're not so good at preventing relapse, second cancer, organ failure, endocrinopathies, or even psychosocial distress. So I think this brings up a number of research questions related to late effects. In terms of prevention, as I've alluded to, it'd be good to know what late effects are attributable to the transplantation itself so that we know what our targets are. We also don't know the spectrum of late effects with newer treatments. By definition, late effects are late effects. So we don't have a lot of patients who have had the newer types of transplants, umbilical cord blood, reduced intensity conditioning, some of the newer GVHD prophylaxis. We don't know what their spectrum of late effects is going to be in 5 or 10 years. We also don't have a really great way of telling who will develop late effects. And you really would like to identify your high-risk population if you want to start testing preventive strategies. I think there are credible strategies for preventing cardiovascular toxicity, renal complications, and bone loss. We just don't always know who to target those studies at. In terms of treatment, should treatment thresholds or management approaches be adjusted in transplant survivors? And what do I mean by this? Well, we have a lot of patients after transplant who have hypertension and diabetes and hyperlipidemia, but they're on a lot of drugs, they have a lot of comorbidities, and we don't always know exactly how to treat them best. So can we extrapolate from general population studies? Is the risk reduction of treating these things going to be as beneficial as someone who doesn't have all of these competing risks? So in 2012, 7 transplant societies, including the Asia Pacific Blood and Marrow Transplantation Group, which many Indian hematology programs belong to, we all got together and we updated the recommended screening and preventive practices for long-term survivors after hematopoietic cell transplantation. And I just wanted to acknowledge all of the people from India who are part of that group. And there were a couple of derivative publications out of this work. One was a patient version of the guidelines, and one was a physician version of the guidelines. And the idea was to take this very long and very dense paper and really distill it down to checklists that patients and physicians could look at in order to guide their survivorship care. And the current recommendations for survivorship care really focused on these things. So prevention when possible, screening and early detection, recognition of late effects, appropriate interventions, acknowledging that there's little data in the transplant survivors and that we need to extrapolate from other populations. Unfortunately, I was part of this group. What was disappointing was there was little substantive change from 2006, the last time these guidelines were published. So I just wanted to share with you what a one-year survivorship or long-term follow-up visit looks like at Fred Hutchinson, when I'm from, for an allogeneic survivor. We do a complete blood count with a differential, chemistry panel, so liver functions, glucose, creatinine, do your urinalysis, a fasting lipid panel, virology screen for hepatitis B and C and CMV, immunization titers. We do an endocrine evaluation, so test thyroid function tests and sex hormones, do iron studies, immunosuppressive drug levels. We restage the patient with a bone marrow aspirate or CAT scans, pulmonary function tests, a DEXA scan for bone density. We do eye and dental exams, a gyne exam, and a mammogram, and we give them 8 vaccinations. So this is consistent with the recommendations that came out of that panel. And should anyone actually want to see what these guidelines are or what the Fred Hutchinson does with them, these are available online. It's intended to be guidance for referring physicians. It's about a 100-page document. It includes a brief literature review and then very specific detailed recommendations. And if you just remember www.fredhutchinson.fhcrc.org, then you can click down and find it. But I think what we're starting to realize, and this is from a nice paper by Navneet Majal and Doug Rizzo, that surviving the cure is complicated. So we do all these things to patients, we give them this incredibly intensive therapy, and then they're left with a lot of late effects. We can make recommendations for those late effects, but there are some barriers to actually delivering that care. And what these 2 authors said, and I think it's the feeling of a lot of people, is that survivorship care for late effects is limited by lack of time, money, interest, and knowledge. So you can do all the recommending you want, but what's actually happening out there? So I think this brings up a number of other research questions. So if the goal is to decrease morbidity and mortality from late effects, it's important to know what testing is necessary, what is reasonable, and what is a luxury. What aspects of the guidelines are most important? And I would argue that this should be based on the incidence and the severity of the problem, but also, very importantly, the availability and the effectiveness of treatments. Why screen intensively for something that you can't do anything about? What care model works best for survivors? This is quite a bit of follow-up. And should the treating physician, the person who actually did the transplant, do the follow-up? Or should there be a centralized survivorship clinic that actually has expertise in all these late effects and managing these things that sees the survivor? And this is a big struggle in the United States right now to figure out what is the best way of delivering this survivorship care. Should it even be the hematologist? Maybe it should be the primary care physician or the pediatrician who takes care of these things. And then giving the giving limited funding for survivorship care, where is that money best spent? And so this is my most controversial slide. I put it up here to stimulate discussion and to put something out there that people can comment on. In my belief, these are the highest priority late effects monitoring that one should do. I'm going to assume that you're doing routine visits and basic laboratory monitoring, which means glucose, creatinine, and liver function. I think this is really important. This is actually not happening in a lot of places. Many survivors sort of go off and don't get this kind of just routine follow-up. Just keeping in contact with the survivors, letting them know to expect late effects and to monitor them for that, I think is very important. I'm also excluding disease monitoring and chronic GVHD management, which are sort of their own separate things. But in my estimation, based on disease burden and the available treatment options, I think the 4 things of highest priority would be, in my mind, infectious prophylaxis, so both antibiotics, antivirals, and vaccinations that are appropriate. I think thyroid function tests every other year because we know that's very common and very treatable. A mammogram if women have had radiation therapy, and a pap smear because we know that the rate of breast and cervical cancers are high, and again, early detection is key for these diagnoses. And a DEXA scan at 1 year because we also know that the rate of osteopenia, osteoporosis is high, and there's very many readily available treatments. I think that if you can do it, a lipid profile at 1 year is nice. We know that hyperlipidemia is also very common and associated with cardiovascular events. And I put on here an annual dental exam, both for screening for second malignancies, as well as because we know that many patients have serious cavities afterwards, and we don't want to forget oral health. So just in summary, I hope I've shown you that transplant survivors have higher rates of mortality, so 2 to 9 times, and higher rates of chronic health conditions, so 2 to 4 times compared to the general population. And these late effects are associated with worse quality of life. I think approaches to survivorship care depend on the incidence and severity of late effects, the available options to prevent or treat the late effect, the health care resources that you have available to you, and your healthcare delivery systems. But I really urge you to see this as just part of the continuum of the transplant process to realize the toll that it could have on your survivors and to develop recommendations within India to follow up these survivors. And so this is just a picture of Fred Hutchinson with beautiful Mount Rainier in the background. And I'd like to acknowledge the National Cancer Institute and the Office of Rare Diseases Research, who really funded all of my work in late effects. Thank you very much for your attention and for inviting me.